So I'm going to talk about deep brain stimulation surgery, and I'm sure most of you, at least I think, have heard of it. Is that right? I would think everybody's at least heard. There's a lot of unknowns for kernicterus, which is what we'll try to address to some extent, but unfortunately there really is a lot of unknowns as far as for kernicterus. So I'm going to try to talk a little bit about the surgical history and give you all an idea of where this all came about, then talk a little bit about why does it even work, and then talk a little bit about the technique, how we actually do it, and what are the outcomes in dystonia. Again, for kernicterus, there's not a lot known, but I'll still mention what we do know, and an experience in kernicterus, which is what I mentioned. I'd like to keep this as informal as possible. I know there'll be a little time constraint, about 30 minutes maybe, so it'd be hard to take too many questions, but if I say anything that's clearly not understood and I can answer it quicker, if I can explain it better, please ask. So this is the brain, and we don't have a pointer. See my mouse will work, that'll be fine. So this, again, is the brain, and certainly this gives you a good idea of where in the brain we're trying to go. Somewhere in the middle is really where we're trying to go. And there's these different connections, and I circled over here this big circle, and that's really our main target, which is the globus pallidus internus, the internal portion of the globus pallidus, or the GPI. There's other targets. Another target that's been popularized but is less popular now for dystonia is the thalamus. There are other possible targets, but these areas all interconnect, and they form what are called the basal ganglia. And the thalamus is where the major part of the outflow, or one of the major outflows of this area called the basal ganglia. So that's to orient you. So when I talk about the surgical history, you'll have some idea what these different names are, these different places in the brain. So surgically, what happened is in 1952, Irving Cooper, a neurosurgeon in New York, was operating on a patient for Parkinson's disease for a reason that had nothing to do with his Parkinson's disease. And while he was operating, he accidentally tied off a blood vessel, made a mistake actually, and the patient stroked into the basal ganglia. And the patient woke up from surgery. The Parkinson's disease on the opposite side of the body was all better. So based on that, fortuitously, people realized that maybe we should start doing these surgeries, because back then, this was before we had a drug, dopamine, which really treats Parkinson's disease. We didn't have that. So in the 1950s, Irving Cooper and some other folks, especially Irving Cooper, really popularized surgical approaches. And by the 1930s, by 1970s, the first report of a case of a thalamotomy, otomy meaning hole. So they actually made a hole into the thalamus, which is the area, one of the areas I showed you, which is over here, right? So they made a hole into that area to treat dystonia and reported some modest improvements. Deep brain stimulation surgery, which I'll talk about in detail later, the technique, it's actually putting a wire in. So you're putting a wire into the brain and not making a hole. The idea there is the surgeon has a little more leeway to make some mistakes. It also allows you to adjust. So you're not actually making a hole, it's reversible. So you put the wire in, if it's not in the right place, at least you shouldn't have damage. And again, you can adjust the parameters of the stimulation. We think, at least I believe, and most people would believe, that the stimulation is actually doing the same thing as a hole and turning it off. But there are some other people that believe that you're actually turning those cells on and not turning them off. So moving to the 1980s, in the 1980s there were some other areas that were being done, or this was the first time that apart from the thalamotomy, people were actually starting to put those deep, I'm sorry, let me back up. 1972, the DBS came out for intractable pain. That's where the original use of it was for. So they were putting it into various brain, spinal cord areas to try to block pain. And then the idea came, well, let's try that for involuntary movement. So they targeted the thalamus, the cerebellum, some other area of the brain for involuntary movements in around 1980. It was reported. By the 1990s, pallidotomy, making holes into the globus pallidus internus, became really popular and became really in vogue, and lots of patients began getting this procedure. By 1996, the first case report of actually doing a pallidotomy for primary dystonia. By primary dystonia, you all probably are familiar with these terms, but in case you're not, primary dystonia is when there is no brain changes. It's felt to be a focal dystonia. So you have, not focal, but you have a dystonia without anything else. And it's no cause unless it's a genetic cause. So someone who has kernicterus, that's secondary dystonia. It's due to particular damage that happened, as you know. So those are secondary dystonias. So primary dystonia, the first case report in 1996. By 1999, DBS for dystonia was reported. And so why does DBS work? I mentioned these pathways. Again, no one's taking notes happily. But basically what we know is a lot from Parkinson's disease. What we know is that dopamine is made here at the top of your brainstem and goes up to an area called the striatum. From the striatum, there are pathways that go down into the globus pallidus, which I mentioned was one of the target areas. There's also pathways into the subthalamic nucleus, which is sitting here. These pathways, the subthalamic nucleus goes back to the globus pallidus, and ultimately the outflow goes to that area called the thalamus, up to the motor cortex at the top of the brain and down to your arms and legs. So again, there's a circuit here that, if interrupted, can really improve Parkinson's disease and dystonia to some extent, and I'll discuss that in detail later, to what extent. So this is some studies that I did when I was at Emory before I came to Richmond. And what I did was I recorded in some primates, some monkeys. And what I did was I recorded in the GPI to see what the normal activity looked like. And what you see, are actually recordings from the brain. And what you see are these regular firing patterns of brain activity in that area. If you created dystonia in the animal by giving it a drug, so you could actually create dystonia with the drug that would last 2 or 3 hours, which was nice because you still had a normal animal when you were done. And what you had was you had some periods of activity that showed dystonia, so you could compare the two. And I probably shouldn't use the word normal because we're all normal, but normal as in not dystonic, sorry. So during this time that the animal was dystonic, you could see the changes in activity. And what you see is these cells that used to fire in a regular pattern would start having these clumping of activity. So you could actually see these clumpings. And it's even more obvious in the external part of this globus pallidus. If you record in the undystonic state, the cells fire, pause. And if you create the dystonia, it still fires and pauses, but there's much more clumping of activity. So if you actually record from the biceps muscle and the triceps muscle, the hallmark of dystonia is co-contraction. So in normal, regular movement, you should be able to do this while this relaxes, and then when you go back in this direction, this should contract, and the biceps should relax. And in the case of dystonia, that's not what happens. They both contract and fight each other, which may be a cause of some of the muscle cramping that I heard about yesterday. Maybe this competition between the muscles and excessive cramping. And if you record from these brain cells, so this is the GPI, which I mentioned was the main target, what you see are these clumpings, and you see an incredible buildup of activity of the neuron, the brain cell, right before the muscle activity. And you can see that here and here. So it looks like this area is really overactive and really driving driving the muscle activity. All right, so how do we, what's what about the surgery? What's the technique? What you do is you take this wire, which you see here, and you put it into the target, usually the globus pallidus internus, and you connect it to a wire and a battery pack that sits under the skin. This is made by Medtronic. It's actually the same thing you would use for a heart stimulator. It's the same company. So in this case, instead of creating activity, we're probably blocking the activity by overstimulating these cells. We're actually turning the frequency up beyond 100 hertz. So it's actually stimulating over 100 times per second, which probably is so fast that it actually overtakes what the cell is trying to do and shuts it off. So again, surgical targets. I mentioned the GPI, the thalamus. Another target that we were thinking about, or at least I was thinking about and investigating maybe in our animal model of kernicterus, was the subthalamic nucleus, which I'll mention a bit about later. But again, the important thing is these areas all interconnect and are important for motor control. The globus pallidus is the liver is important for kernicterus, as you know, but the brain is not the liver. It's very well organized. And in the case of the globus pallidus internus, there's an area here in the back that's really the motor area, and that's really the area that needs to be targeted for these surgeries. The area up in front of that, which I'm showing you in blue, is really not the primary motor area of the globus pallidus. So when I was, these are earlier studies I did. These are actually done in the monkeys. And what these are showing you is, if I can orient you, this says, if you can see the L6, that means lateral 6. So that's 6 millimeters from the middle of the brain. And lateral 11 would be 11 millimeters. So it's progressively, these are sections through the GPI and GPE, moving progressively more away from the middle of the brain. And so it'd be like you took sections. Let me back up. So this is the front of the brain here. This is the medial part of the brain, more in the middle. So again, on this section, the lateral would be way out here, the medial would be way here. So if you can imagine going through that, the first section should have very little motor. It's only when you start getting lateral that you would start getting the motor and be into that purple area. This purple area that we're targeting is about the size of a pea. But it's important that not just that you're in that pea, but that you're in the right part of that pea. So it's a very small area you're targeting in the brain, but you need to target the right part of that pea, or you may not see the right improvement. If you look at this, this is the most lateral section. If you see that, what I'm showing you here is when I recorded in the animal, what these red responses are. If you moved the animal's arm, the cell would actually change its firing. You could hear it changing as you move the arm. You were driving the cell. If you're in this area here, the blue, you're driving the leg. So you move the leg changes. And again, as you move more and more medial towards the middle of the head and more to this blue area, you start losing the real motor area. So hopefully that's clear enough. So what I did with these were animals that we induced Parkinson's, so we could actually have a model of Parkinson's disease. And then what I did was I injected small amounts of a drug that could actually shut these cells down, as if it was making a pallidotomy, but it would be reversible. So you'd shut these parts of the brain down for a few hours and it would come back. And what was clear was this big square is where would be the maximum improvement. And this is generalized improvement. This is the arm improving. And it was clear that there was an area, this colored part that's green is the motor area. This is where we could actually drive those cells to change activity that we'd know would be in a motor area. And there was a particular area, and it was very focal, that if you did the injection of this chemical to silence the cells, you'd see a dramatic improvement in the animal. But if you moved only a half or a millimeter away, the improvement would either not be there or would be minimal. So it was clear that there's an area that's really critical. And if you compare that and extrapolate this to the human, it would probably be an area sitting right there that you'd want to target. So a very small area within that pea. So if you can imagine putting your stimulator back here, you might get very little effect. If you put it here, you might get no effect. But if you sat it right there, based on the animal study, you'd predict a dramatic improvement. All right, so how do you do this surgery? First thing you do is you do the MRI, the brain scan. You could also do a CAT scan to localize. And this is a 3D way to look at the brain to try to home in on the target. And the surgeon can do a good job and get you within 2 or 3 millimeters of your target. But as I explained, that may not be good enough. So what do we do to improve that? Well, what we do is we take a little electrode and we put a wire into the brain. This is the electrode here, and this is a dime, a familiar object, and gives you an idea of the size of it. Our approach would be from the front of the brain. You want to come in from less eloquent areas. If you come straight down through the motor area, you may cause a paralysis. You come from the front of the brain, and you work your way in. So this would be to simulate what happens during surgery. Uh-oh. Mine's blinking, but that's not. Okay, stop. So simulating what you would do during surgery, as I mentioned, you'd come from the front of the brain, targeting the GPI, this area right here. Again, this area, the motor part of that, again, would be like a P. From here to here, from the top to the bottom, the largest extent is about 6 millimeters, so less than a centimeter, about 1/4 of an inch. As you're coming through the putamen, then you enter the GPE. As I mentioned, the GPE, these are some recordings. You would see this firing, pause, firing, pause. As you enter this area called the border zone here, you see cells that fire very, very slowly. They just fire very slowly, monotonously. Then when you come into the GPI, suddenly it becomes very active again. So this is a roadmap. It tells you where you are. So I'm going to give you some recordings, some examples. As you enter this putamen, as I mentioned, these cells fire very quiet, very, very quietly, very slowly. These are actually recordings from not a dystonic patient, but a Parkinson patient. As you work your way down further, you would enter the GPE. As I mentioned, the cells fire and pause, and they move much quicker. As you move into the border zone, you see these cells that fire slower again, more monotonously. And then when you enter the target, the GPI, things become very active. And you know you're in the right target. As you go lower and through the GPI, you can enter, depending where you are, either the optic tract. That's your visual tract. As you're in that area, if you shine a light, you can actually hear the fibers stimulated. So you can shine a light and you're every time you shine the light. That tells you you're over here. If you're back here, a little bit further posteriorly towards what is called the internal capsule, that's the fibers that come right from the head all the way down your arms and leg, you actually hear what sounds like a sharp, crisp fiber sound. So this would be simulating what would happen during surgery. These are cuts from an atlas. This is taken from a brain atlas. We could actually take the individual patients and create a similar atlas for each person. But it turns out that if you use the human atlas that's available, this works very well. And there really doesn't seem to be a huge advantage of using the individual person's brain. So this, again, to orient you, lateral 20. So again, this is a human, so the numbers are going to be bigger than what I showed you with the monkey. So this is lateral 20 to lateral 24. 24 would be 4 more millimeters over from the midline than 20, so you're further over. And as I mentioned, you want to be quite lateral. You want to be quite over into that purple area. So what I've drawn here in yellow is the target, the GPI. If you made a first track, for example, and you recorded and you saw that you had some of this striatum, some of this GPE, some GPI, then you found out that you ended up in the fiber area. which I mentioned, and not the optic tract, you would probably place this track right there. So basically what you do is you make a recording, you take that information, and you see where it fits best on the brain, and that tells you where you probably are. And again, when we're in the GPI, much as we would do with the monkey, we'd move the arms and legs to see if we get a response. If we do, at least we know we're in the motor area. It doesn't tell us we're in the right area of the motor, but at least it says we're in the motor area. So let's say we didn't see any motor response. We'd say, well, let's move towards the purple area more, and we'd do another track. So we maybe would fit like that. We get to the bottom, and we see the optic tract. We shine the light. And on the way down, we saw these leg responses, as I showed in blue, and arm responses in leg. Then what we would do is we would turn on the stimulator. If we actually saw the improvement there in the operating room, we'd know we're on target. These patients everyone's wide awake during surgery. It's critical you're wide awake. It allows us to know if we're on target because we can turn it on. Occasionally, we've had to do this under anesthesia, but it's not ideal. So what are the surgical outcomes? Let me just warn everyone first that this would be the ideal situation. This is a girl who has DYT1 dystonia. That's a genetic variety of dystonia. In the literature and from everyone's experience, these are the people that do dramatically well, as I'll show you. It may be a little unrealistic to hope, at least at this point, from targeting the GPI, which would be our target now, to expect this kind of outcome. So I just want to warn everybody. But this is what we'd like to be able to do, and I'll talk at the end about how we might have some hope of approaching closer to this than we can now. So this is a girl. This was a case from 1998. It was published. It was one of the it was the earliest video I saw of someone with dystonia who actually underwent surgery, and it's really dramatic, the benefits. So she had pallidotomy. Again, otomy meaning holes. This was before we even were doing DBS. And by bilateral, I mean always both sides of the brain. There's even talk that someone like her, if it would have been done earlier, before she developed all the tightness, may have been given everything back.
How long does this last?
Well, that's an excellent question, and I would love to know how she's doing, and I really don't know. We believe it will persist, especially with a condition. It may be different in a condition like a genetic variety. With kernicterus, you'd like to think that whatever you could reverse would stay forever, but we don't know that.
So it's never been tried?
If I can get to 2 more slides, but I know that's what you want to know. I should. All right, I'm sorry. That should have been the first slide, right? You're torturing us. Sorry. So this is a guy we just did, and I think this may be more realistic of what we could hope for with treating people with kernicterus. So this is someone who had generalized dystonia. No, he looked a lot like she did, but he was genetically tested and was negative. Whenever you test for the gene and it's negative, the results are not usually as dramatic. So I think this is what you might, at this point, we could probably hope for. Pay attention to his right foot, which turns under really almost completely, and watch his left leg as he sits down. This is a film that someone just made for me. I didn't actually select which parts. His left leg turns out, his left arm would do the same thing. Anytime he tried to do anything with his left arm before surgery, it would basically just straighten out.